So I want you to help me welcome Dr. Nicole Vermans and Dr. Sheila Riazzi. Both are esteemed members of the RYR1 Foundation's Scientific Advisory Board and experts in neuromuscular disorders and malignant hyperthermia. They will lead today's session on understanding rhabdomyolysis and malignant hyperthermia.
Thank you for the introduction. Yeah, we're very pleased to do a co-production here. Sheila and I have been working together for a long time, and it's nice to be on the stage together. We have different backgrounds, different continents, and I think we're very complementary. First of all, what is rhabdomyolysis? And I think the term has been used very often, and I've talked to quite a few people who've had an episode of rhabdomyolysis. And it's not a disease, it's a symptom which occurs in a certain number of days and is characterized by muscle breakdown, mostly elicited by exercise or by other triggers, and it results in dark urine and often also weakness in certain muscle groups. And if you look at the medical books about this, we have a definition based on 5 features. There are symptoms of rhabdomyolysis, which I just mentioned: myalgia, tenderness, swelling of the muscle, weakness. And it's not weakness all over, it's weakness in the muscles that have muscle breakdown. Myoglobinuria is the term used for the protein myoglobin in the urine, and it colors the urine dark, so it's a cola or coffee-colored urine. And then the CK elevation. CK is creatinine kinase. It's an enzyme present in muscle, and because of the damage to muscle cell, it will be elevated in the bloodstream, usually at a peak at 12 to 36 hours after the exercise or other triggers, lasting up to 3 or 4 days, and that is elevated several times above the upper limit of normal. And that normalizes again afterwards, or goes down significantly. And these triggers can be variable. I already mentioned exercise, and that's not usually exercise as part of the usual routine. It's exercise beyond limits of fatigue or myalgia, or involuntarily exertion. And it, as such, occurs more often in team sports, in competitions, in army activities, where people try to go beyond what they're usually doing. Dehydration or high temperatures might be a trigger. The use of supplements or certain medications. And the occurrence of viral infections can also trigger rhabdomyolysis. And here you see a figure of this increase of myoglobin, this protein, which is part of muscle cells, and the increase of CK, which is a bit later. And the trigger occurs at the time point 0, and then 24 to 72 hours afterwards, you see the highest CK increase. Myoglobin would be detectable at an earlier time after the trigger, but most laboratories in general hospitals do not offer this as a standard test anymore. So that's why we generally use CK as a measure of rhabdomyolysis. It is a medical emergency because there is a risk of acute renal failure, so decline of function of the kidneys, and that can cause very many different medical problems. It is challenging because different medical specialists are involved. I'm a neurologist who has experience in rhabdomyolysis, but I'm not the one at the ER at Friday night at 8 p.m. who will see the first patient with rhabdomyolysis. There will be an ER clinician, and if it's a severe event with signs of renal failure, someone will be admitted at the intensive care unit, and then you have an intensive care medical specialist. And sometimes it is less severe, and people will be admitted at the internal medicine ward, and then you have an internal medicine specialist. And because it is not very common, many clinicians have limited experience with rhabdomyolysis. So again, what I already mentioned, be patient and supportive. Do not blame the clinician for not knowing it. Just telling, I'm a peculiar case, you can learn of me, and this is what you should do. Take on information with you, and it's not that you're going to tell the doctor everything, but just acknowledge that you have something which is rare, and that you do know some references to find more information. And then, as I said, rhabdomyolysis is not a disease. It's an event which can happen with a combination of a certain underlying susceptibility when exposed to certain triggers. So it's a combination of a susceptibility and a trigger. A susceptibility might be an acquired disorder. People who have severe reduction of the thyroid function, for example, at the onset when they're being diagnosed, they have increased risk of developing rhabdomyolysis. There are also people using a certain set of combination of medications which makes them more susceptible for developing rhabdomyolysis. But there are also a number of genetic conditions, one of which is certain rare one variants. And what I often explain to patients that if you don't have an underlying genetic or acquired susceptibility, you can still develop rhabdomyolysis if you're doing things which are far beyond the limit of exertion. If you have a genetic susceptibility, such as some of you in the room, you just have to be more careful. You will most likely develop rhabdomyolysis when exposed to less triggers than someone without a genetic susceptibility. And what can you do yourself if you think you have such an episode? First of all, drink lots of water and go and see a doctor if your urine is remarkably dark, if you start having less urine production, if you feel muscle weakness, or if you have a general feeling of unwell. And a general practitioner or the ER clinician can do a general blood test including CK, transaminases, minerals, sodium, potassium, and check the kidney function. And then with these and some other laboratory measures, the ER clinician can assess the risk of renal failure. Gerard McMahon is an American doctor who made this score based on a large study he performed on rhabdomyolysis, and it will tell you what the risk of renal failure is when having an episode of rhabdomyolysis. And it's very helpful, because if you're a healthy individual and you don't use medication, you've not been drinking alcohol, you've not been using illicit drugs, and you have rhabdomyolysis following an event of strenuous exercise, you will most likely have a very low score on this scale, even if your CK is 35,000. And this will help the clinician at the emergency room to become a bit more calm, maybe, and see, okay, this is okay, we'll manage this. And someone does not have to go to the intensive care unit, but can be administered at a general ward. So keep it in mind, keep this with your notes. There's an internationally acknowledged score for assessing the risk of renal failure, but not all ER doctors will be aware of this. But there's a link on the presentation, and it's freely available for anyone. And what can you do to prevent these triggers? Prevention of triggers of rhabdomyolysis is in fact the same as in other individuals who do not have a genetic susceptibility. You just need to be a bit more careful. And what is very important to keep in mind considering sports, refrain from doing too much, too soon, and too fast. And these three words are from an article by a sports medicine clinician, Eichner. He's from the United States, and he's written numerous reports on teams, professional sports teams who have had, he said, outbreaks of rhabdomyolysis. And an outbreak, that term is usually used for infectious diseases, but we've seen over the years many sports teams who, together with their trainer, go beyond their limits of exertion and then have an episode of rhabdomyolysis without an underlying genetic condition. But if you have a rare one variant, you've had an episode of rhabdomyolysis, or you're known to be susceptible to MH, be careful in doing sports. Start low, go slow, and stay away from too much, too soon, too fast. And also other triggers. So it seems very common sense, but don't go running at noon in the mid of the summer, because then you're exposed to much heat. And many people in the Netherlands compete in running competitions, and they train very carefully early in the morning, late at night, but then the competition starts at 11 a.m. or 12 at noon. And people just don't realize that they are at risk of developing rhabdomyolysis, even in possible combination with heat stroke. And it's also the humidity which plays a role. So that's something to pay attention to. And again, know what you have, take information with you when traveling. I've been sending out medical articles as homework to some of the people in the room, but just keep a PDF file in your phone or in your computer, have it on you whenever you're traveling, and if you're somewhere where the clinician doesn't know it, you can provide the knowledge. And here you see the report of an ENMC workshop. These are workshops held in Europe on different neuromuscular topics with experts from all over the world. And we had a workshop on rhabdomyolysis last year. There were a number of participants from the United States, one of which is Francis O'Connor, who's a clinician in the American Army, and he provided very good insights. And there's a lot of knowledge about prevention and treatment of rhabdomyolysis among the Army physicians. And here you see examples of bracelets where you can use a metal bracelet, but also other bracelets to be used as an in case of emergency signal. And these are examples of emergency cards you can carry on. This is the schedule from this article from the ENMC workshop, which is provided to the clinicians worldwide to give guidance on what to do when someone comes with an episode of rhabdomyolysis. In a case when there is no exercise as a trigger on the left, or when there is exercise as a trigger. And if the CK is below 5,000 in case of absence of a trigger, or below 10,000 in case of exercise as a trigger, it's generally okay not to go to the hospital. And then you see the flow chart, which you can find in the article. And if you're interested in it, just come and see me and I will send it to you. It also provides guidance when there is not an underlying genetic predisposition known, in which patient you should start searching for it. Because if someone has had one episode of rhabdomyolysis without a known genetic susceptibility, and the CK is only 12,000, and someone recovered rapidly, and there are no other family members, most likely you do not need to search for it. But that's not for the audience here who already knows that they have a malignant hypothermia susceptibility. There are different genetic predispositions leading to susceptibility for developing rhabdomyolysis, and the RIR1 is one of the genes, but there are a number of other genes. And I've talked to someone who was diagnosed with McArdle disease before RIR1 gene testing was performed, so it might be the case in some others of you, because that is a disorder which has been known for a much longer time and also can present with recurrent episodes of rhabdomyolysis. Do we already switch here? Next one. Yeah. Okay. Rhabdomyolysis is one of the complications which may take months to recover. And at least 1/3 of the MH susceptible patients develop rhabdo in absence of an anesthetic trigger, with triggers as I have mentioned. The more rhabdo events, the lower the threshold for individuals to develop another episode of rhabdomyolysis. So if you've had 4 or 5 episodes, you should most likely be more careful with exercise than others. And oral dantrolene can be used to treat, prevent, or even lower the severity of these episodes of rhabdomyolysis. And that's what Sheila has mentioned before. And now we're going to switch.
You've seen this before, so I guess I'm not going to... Then no, it's back-to-back session. So this is, as I said, is an example that rhabdomyolysis from heat and exertion existed in a known MH, anesthetic-induced MH susceptible family. So I'm not going to go through that for those of you who already saw this with the last one. But I just have a couple of cases also to present. One of them is this gentleman who's a patient of mine, 24 years old. He's not a professional athlete, but he works out in gym like at least 3, sometimes even 5 times a week, and quite a bit, like actually an hour or an hour plus. And he does all types of modalities, cardio, weight training, everything. He also, on top of that, plays soccer. And so one day after soccer, he noticed that he had cola color urine, and he then started. He had repeated exertional rhabdo 5 times that year. And he was tested for some of the abnormalities or other metabolic diseases that can also cause rhabdomyolysis. And then during those genetic panel testing, he was found to have 2 VUS variants in RYR1. And he came to us. We first did a contracture test, which was positive, and also we did a histopathology, which did not show any major structural abnormalities. But he was quite devastated because, as he was saying himself, that now, first of all, I'm afraid to go to gym. And he was kind of, once you do the exercise, you kind of get addicted because it boosts your endorphin and it makes you feel better when you, exercise. So he was quite depressed because of that, and he also traumatized. He was saying that every time I go to gym, I do 10 minutes workout and then I stop because I think there's going to be another episode. So unfortunately, his life was quite disrupted. Anyway, so what happened here was his last episode before he came to see us was he had a CK of $135,000, and this is a guy who was 6 feet tall and under 200 pounds though, but very muscular. So he wasn't too big, but quite a bit of a CK. But baseline CK was going down to 180. So he recovered beautifully. So when he came to see us and we made the diagnosis and everything, I told him, why don't you take dantrolene, at night, just every night. So he started taking it 25, and then he went up to 50 milligram. And then the next time he had the exertional rhabdo was 4 months after we started him, and it went as high as 38,000. To me, that was actually success, but still, we had work to do. So I told him, you know what, did you feel anything? And this episode happened with viral illness, with upper respiratory tract infection. And he says, yeah, as soon as the first day when I had this, and then the next day I felt that my muscles are sore, and then the 4th day he went to emerge. So when you feel and starting that you're feeling that your muscles are hurting, take extra dose and contact me. We can up your dose, not just the 50 milligram at night, but you can take it during the day, and we can also, like 50 milligram 4 times a day, or even at night dose, we can go up to 100 milligram. So the next time, he did that for the next time, and it went up to 8,000. And after that, we kept the same regimen because I thought, 8,000 is good enough. And now he gets episodes every now and then, and he has record, like a lab requisition. So every time he feels, he just goes to the lab and they take his CK serial CK, and it hasn't gone higher than 3,000 with this regimen. So it was quite a success for him, because now he goes back to gym. With his 50 milligram at night, he's still, like he says, I can't go to gym in the morning. I have to go in the middle of the day or at the end of my work, because in the morning I still feel a bit of weakness. But he's afraid to bring it down to 25 at nights. But anyway, it works for him, and he hasn't had any major episode since. This is your part.
Based on discussions I've had with Sheila and with the anesthesiologist Mark Snook in my hospital, we decided to start looking at symptoms people with malignant hypothermia susceptibility report, because as Sheila mentioned, for a long time it was thought that MHS and congenital myopathies are 2 separate groups, but over the times we learned that there are people with malignant hypothermia susceptibility who do report muscle symptoms, and that there are some older individuals who do develop some muscle weakness. So we thought, is it really separate, or are these two groups overlapping a little bit? And that's why we started a study approximately 5 years ago. It is on neuromuscular and multisystem features of RHEA1 related malignant hypothermia and rhabdomyolysis. So these were 40 patients in the Netherlands who were from an MH family and had an MH episode themselves, or were MHS based on genetic testing or in vitro contracture testing, or had an episode of rhabdomyolysis with the RHEA1 variant, which was associated with malignant hypothermia. And we did what we call prospective study, so we invited 40 people, several days. We did a fixed study protocol in all of them, consisting of a neuromuscular history, so asking about neuromuscular questions, looking back at all the electronic health records, assessing them clinically, so performing muscle strength testing, doing a muscle ultrasound, an MRI scan, and a number of functional tests. All patients were Dutch and were 18 years or above, and people were not supposed to have muscle weakness as part of a myopathy, such as central core disease, or other causes of muscle weakness, such as another muscle condition. They should not be using steroids, drugs like prednisolone, because these are known to cause muscle weakness, and we excluded patients who were pregnant because of the functional tests which had to be done. And the neuromuscular questionnaire, so we used a number of standardized questions in individuals, but we also asked people without MAS or rhabdomyolysis of the same age, the same questions. And what we found is that people with MHS or exertional rhabdomyolysis, in comparison with individuals of the same age without this condition, had more often muscle cramps and myalgia, had more often muscle weakness, reduced exercise capacity, reported more often previous episodes of myoglobinuria, and had other neuromuscular symptoms, and also more family members with neuromuscular symptoms, showing that the MHS phenotype is more than only an anesthesia-related risk. And many of these patients had visited several clinicians before, so they had seen their general practitioner, or a rheumatologist, a physical therapist, an occupational therapist. They went to see an orthopedic surgeon, or a sports physician, or a vascular surgeon, asking these very different clinicians, do you know what the cause of my muscle symptoms is? And hearing the conclusion of our study that these symptoms are most likely in most individuals related to the malignant hypothermia susceptibility was reassuring to them. They said, I would have liked to have known that before, then I would not have been so worried, and I would not have had a muscle MRI or a muscle biopsy or an electromyography, and would not have gone into all these tests. So we said, well, it's important if a geneticist or an anesthesiologist diagnoses an individual with malignant hypothermia susceptibility, that there's given some additional information about the symptoms which may occur in between. And we never want to make patients more ill or make them more patient than they are. So it's not about giving patients additional symptoms which may occur, not making them worry, but just reassuring them, be aware that this condition is not only something which causes a risk for malignant hypothermia during anesthesia, but you might also have other symptoms in between. And this is what you can do about it. We've talked to the European Malignant Hypothermia Group about this. Some of the people who collaborated in this study are members of the European Malignant Hypothermia Group. And the PhD student who was the lead researcher in this study is going to defend this thesis, and included an infographic for patients which can support the geneticist or anesthesiologist in counseling these patients. Okay?
It's about you again, Cody. You're the most generous of my patients I can talk about, so thank you very much. We have quite a few professional athletes, and actually lately we have had two tennis player professional athletes who you're helping, which in their world, I was telling Nicole, it's even worse because now that I'm following that, it's, with tennis, most of their, tournaments are during summer, and it's like 3, 4, 5 hours in the hot, really hot ambient temperature, and so they are getting rhabdos quite a bit. But again, they were not open for me, open enough for me to discuss their cases. So I'm going to use Cody's case again here. It says he's now 31. I think it's a few years old. This, yeah. So story of Cody is many of you again may have known, but I think it's worth repeating it. His dad was diagnosed with malignant hypothermia susceptibility, and he had contracture tests, and he had 2 variants in RYR1. And if you talk to his dad, he tells you also that he likes to play hockey, he likes to do a lot of stuff, a lot of exercises, but he was always limited because of, his stiffness and muscle symptoms and all that. Having said that, Cody was good. Initially, when he was a child, he had a bit of symptoms, but I think he grew out of it. He learned how to cope with it, and then he moved on to be an amazing professional hockey player and played in many, many tournaments for many different teams. But he started having some, I guess, and you can talk to him yourself. He started having some symptoms. Maybe sometimes you have these symptoms, it's, you play, you do a lot of exercise, you always get sore. Everyone gets, muscle soreness. So sometimes it's very difficult to take that seriously and say, is this something that I should be worried about or not? And I guess in his case, it just repeated, and probably the pain and all these symptoms got worse to the point that he was identified with a few episodes of rhabdomyolysis with very high CK. And then the whole workup started, and it was again interesting the fact that no one, at least initially when he was seeing different physicians, was connecting these 2 together. That this family history of MH susceptibility with all these exertional rhabdos. But anyway, finally, a very good sport physician. I think he liaised this, and he sent Cody back to us, and we tested him, and he has one of the variants that his dad has. So his dad has 2, and he has one of them. And that variant back then was categorized as, again, VUS, variant of uncertain significance. So in order to make sure that he has this disease, we suggested him going through the contracture test. And he did. He went through the whole contracture test, was very positive. The result, unfortunately, but now we have a diagnosis. We have something to work on. And anyway, so we suggested him to take the Antrolene, but again, the main problem is the weakness. He at that point, I think it was 7 years ago, or 7, 8 years ago, he because of the repeated rhabdos and all these unfortunate, muscle symptoms, he had to step back and retire. Anyway, he came up with some interesting regimen of dantrolene. He found his way to take it, but at much lower doses that are commercially available. And then he, as he was doing the instructions, like hockey and instructing players, and he was playing, he felt he was in a good shape. And he thought, okay, I'm not having much of those symptoms. I feel well. He was very diligent in the fact that he was checking his CK very repeatedly, making sure that it, stays under 1,000. And he went back. He went back and started playing. He scored quite a few goals. I watched your games actually. Very proud, and and so it was a nice comeback for him, and I think maybe some kind of a closure as well. Again, please feel free to talk to him. He's very, very generous with sharing information and sharing his story, that's that. And so for conclusion, as Nicole mentioned, patients with RYR1 are unfortunately at increased risk for rhabdomyolysis, and the triggers that we've seen, and you may have noticed yourselves, heat, fever, so your temperature, environment temperature, and intense exercise, viral illnesses, upper respiratory tract, COVID event, and also some medications, and obviously alcohol. You know that as well. Education awareness it's crucial at every step of the way. Patients, physicians, and as Nicole mentioned, ER doctor, intensivist, everyone has to be aware of this. And when you are symptomatic, we are very encouraging to have your CK checked. You have a level to refer back. CK level, again, as Nicole mentioned, is a delayed response. It's not going to happen within hours. It starts to go up for probably 8, 10, 24 hours, may peak at 36, 72 hours, depending on the course. And it's very recommended that serial CK to be done until you see that it's starting to come down, because we need to know how high the peak would be. And recurrent episodes, unfortunately, can cause quite a bit of injury, not just for the muscle, but also kidney, because the pigment in the muscle can saturate the kidney function. And prevention, early recognition, and proactive managements are very essential. Thank you. Question?
I had a question with the recurrent episodes, apparently decrease the threshold for further episodes. Is the receptor being injured, and as such it makes the threshold lower, or what's physiologically thought happening with that?
I don't know, we don't know. It's just based on observation.
Oh.
Sorry.
And then the issue with humidity as a factor is the best judge of that the dew point or the wet bulb temperature?
Humidity is mainly a risk factor, high humidity, for developing a combined exertional heat stroke and rhabdomyolysis. And in certain regions where ambient climate is very humid, these figures are also mentioned, I think, in the weather report. I was in Australia this spring, and I went to make a walk early in the morning at 7 a.m. The sun was already out very bright, and there was this marathon thing. Well, it was not a marathon, a shorter run. But I was really worried, because I thought, it's 7 a.m., it's so humid here, and it's so hot. Will there not be any heat strokes? I think if Dutch people would be participating there, many of them would have a heat stroke. And I even talked to the ambulance nurses there and to some of the people from the fire, said, well, no, this is normal in this region. People are aware of this, so they will drink lots of water and they will stop. They won't run. It's not about competing for the fastest time. It's about finishing, so it's okay. But there's a very great awareness in this region, because it is very humid very often, and there it was also reported on the news what the humidity was. But I don't know how it is here in North America. Toronto, is that very...
Yeah,
it's a high humidity?
It's terrible. Humidex is high. And following up to that, there is a manuscript under revision, hopefully comes out soon, hopefully, by Dr. Dirksen and his group, that actually, in mice model, they showed humidity is an important factor to consider in terms of a trigger.
So I have a standing order for my CK that my doctor has for me. I'm just curious, if I were to exercise, feel bad, check my CK 24 hours later. It's a little bit elevated, but under 10,000. Is there a threshold where you recommend going to the ER? Because I know how to manage if it's quite low at home, but I don't know when it's like the time to go to the hospital.
I think 10,000 is this limit we agreed upon in the international workshop I referred to call it at least rhabdomyolysis, and then see if there are any additional symptoms for which you should go and see the doctor. And you can find it in the ENMC workshop report, so I can forward that to you. It's also open, available. It's not behind the wall, so you can access it easily.
Okay.
And then what you have to keep in mind, I think 10,000 in itself, if you know what you have, that you have a genetic susceptibility, you know there was exercise as a trigger, and you don't have very severe myalgia, you don't have weakness, you have normal urine, you drink 4 liters a day, you have very diluted urine, you're fine.
Okay, so I have a lot of instances where I'll feel the physical symptoms of rhabdo like I did when I had it super severely, but my urine looks normal and I'm drinking a lot of water. And in those instances, I never go to the hospital, but I'm always kind of anxious about should I go? Could it be a problem if my urine looks normal?
Well, it's good. You have the opportunity to test your CK, so you could do that a number of times, so you know approximately when you are. And when the circumstances are as you describe, but you have a CK of 60,000, then you should go to the hospital. But if it's 8,000, 11,000, 7,000, then you're fine.
Okay. Okay. Thank you.
But it's always a combination of triggers, so don't start using anti-inflammatory drugs like ibuprofen at that moment. Don't start drinking alcohol because you think I'm tired of the water, you know. So it's be sensible and wise and know what to do, and make sure that you're not going to add on any triggers. Don't go doing sports already the day afterwards. Wait until you've recovered.
Yeah. Okay.
Hi. We live in New England, which is very humid, and we're very lucky that our elementary school nurse actually came from an ER, so she was actually familiar with malignant hypothermia. So we have a whole plan in place for our kids, like if they seem to be showing some symptoms triggered by heat or exertion instead. But how much time do you actually have? Is it help? This is the first time hearing about medications or we're very new to this. So is it helpful to have those medications at the school on hand, or is it better to just get to a doctor or a hospital? If we have a treatment plan in place, if something happens at the school, I'm just not sure how much precaution we should take.
I think you should see physicians, because every condition is different every time, even if within the same individual, every presentation might be different. So it needs a thorough assessment, thorough evaluation. So no, I don't think that's a good idea.
Okay.
And it's good to realize that all the precautions the nurse takes for your child are generally good for all children. Mm-hmm. So drink sufficient water, don't play in the full sun, keep the children inside at the middle of the day. Mm-hmm. And when she does that with him or her, it's good to do it for the whole group in a way.
Okay.
Hi.
And actually, children and elderly individuals are most susceptible to heat injury in general, whereas adults of adolescence and middle-aged individuals are more resistant to it, but especially young age and old age are most susceptible to the impact of heat.
Hi, what supplements or medications are seen as risks?
Oh, that's a long list. It's all kind of medications which can cause increase of CK. And most of them, because they are damaging the sarcolemma, so the muscle cell membrane somehow, or they influence the muscle metabolism in any way, they are at baseline already causing hyperglycemia, so increase of CK levels. So they're also triggers for developing a very high CK in case of triggers for rhabdomyolysis. If you send me an email, I will give you my email address, then I will reply to you and provide you the list.
Okay, thank you.
Hi guys, thank you. I'm sure there's a logical answer to this as to why it may or may not exist. what's the minimum volume of blood that a pathologist needs to test your CK levels? And second part of my question is, would there be a possibility, or does it exist, a finger prick test to measure your CK?
I think that you don't need a lot of 1 milliliter, very little.
Yeah,
or
2
less
cc's
than
is
that.
good.
Yes.
Yeah, exactly.
But we have a retired professor of biochemistry, and I've been talking about this with him for another metabolic disease, which is McArdle disease, which we discussed yesterday. And he said, well, it is most likely feasible nowadays to do it with a finger prick. I discussed that with the McArdle community, and then I said, well, but maybe people become too focused on it. In your country, where healthcare is not so densely healthcare services are not so densely available as in the Netherlands, I can imagine that it can be very helpful. So I will talk to him again. And just the other aspect we were discussing, is Robin Gillis still active as an anesthesiologist in Australia?
Yes, but their center, are you in Melbourne?
No, just Sydney.
Sydney is...
About an hour and a half flight.
yeah, there's another... No, you have a center in Sydney.
We do. Westmead. Yeah, Westmead.
Yes.
Yes.
Question. You've mentioned it in your papers, and it was one point in the slide where patients with MHS who maybe have normal strength in childhood and adulthood, or maybe increased strength, some of them may go on to develop muscle weakness. At the foundation, we've seen this anecdotally. We've heard from patients. And I guess the question is, do you have any insights on why certain MHS patients develop weakness and why others don't? Any correlations with certain genotypes or certain variants, or number of episodes of rhabdo, or other risk factors that may determine who may develop weakness? Obviously, that's something people would want to avoid. Any insights on that?
In the group of 40 individuals, there were 2 people above the age of 60 who developed proximal muscle weakness and had difficulties walking upstairs rapidly, but were still fully ambulant on a plane surface.
Yeah.
And 2 of 40 is too small of a group to look at genotype-phenotype correlations.
Right. Okay.
One of them was drinking far too much alcohol and smoking, so we had a good conversation about that. But that's where you don't need this study for.
Got it.
And then in addition to that, some of the MH susceptible variants also cause central core disease, but then there's already weakness up front. But maybe Sheila wants to comment on that.
Yeah, so I agree with everything Nicole mentioned. Also, patients who are very not even very, but symptomatic when they are younger, in terms of even their, cramps and muscle pain and stuff, as they age over 60, I would say, they are the one who become more weak. And we had this whole understanding of this is not progressive, but
Right.
There is some progressiveness to it.
It seems, again, at least anecdotal from patients that we hear from, where they say they had these episodes and then after one, they're just never the same, have trouble getting back to work. But again, it's all anecdotal, and so trying to get some more insights on that would be great. We're a little bit over time. I just want to make 2 additional comments. I just want to thank Cody, and I think a round of applause for Cody for being so generous with his time. Cody. Cody, we've done lots of marketing stuff and trying to bring attention to the foundation and to RY1, but nothing we have done has compared to what Cody has done in terms of bringing attention to us. And we did an event last night at a local ice rink, and just from that one event, we raised $500 just from having Cody there and some families coming to skate with him. So, Cody, thank you so much for everything you've done and being so generous with your time and your insights. And, as Sheila mentioned, some athletes don't want to share their story. They're worried about their career or whatever, and Cody's been great and been an open book, and we've all benefited from that. I also want to thank Dr. Riazi and Dr. Bermans. Again, you're not going to find 2 more knowledgeable people on this area. They are truly the world's leading experts in this stuff, and so we are really lucky. And the fact that they were sharing their email addresses, I guess their addresses are no longer up there, so if you didn't get it, no, but the fact that they're willing to make themselves available to all of you, that is a tremendous asset, and again, really invaluable opportunity here. So once again, thank you so much for this. Really appreciate it. Yeah.
Yeah, well, I also want to thank Cody for teaching clinicians that's also very helpful. We had a nice conversation last night, and his story reminded me of the cyclist who was in my presentation, who was 16 at the time, and he really wanted to become a professional cyclist, but because of this, he had to stop his career, and he became a very successful law student. And Cody told me, and I hope I may share, but competition is not only in sports. So if you have to stop doing sports because of this, you can compete in other fields. And that's exactly what the patient in the Netherlands did. And that insight is what I will take to the Netherlands, to the next patients I will see. And we are already referring them to a sports psychologist if they have similar problems. But it's something to realize, which can be very helpful in an early conversation with patients, that it will be different competition, but you can still compete and try to be the best.
Yeah, and I know I just want to add to that, to that point, for patients who were doing whatever that activity was, whether it was athletics at a professional level or, weekend warrior or whatever it was, we oftentimes refer to Cody's story and seeing how Cody has managed, so that the psychological and social aspects of it, and seeing kind of how Cody has managed that transition from performing at the most elite level, that just because you can't do that anymore, it's not the end of the world, that there are so many other things in life than just sports and this and that. You can live a very productive, happy, and seeing how Cody is giving back to this community is just very inspiring to many of the individuals in this room who are kind of going through similar situations. So it's just been a great thing all around that what Cody has contributed to this community. So it's been amazing.